Good morning, I'm Dr. Michael Narvey, and I'm a neonatologist in Winnipeg, Manitoba, Canada at the University of Manitoba, and it's my pleasure to speak to you today about antibiotic stewardship in the NICU. Today I'm going to be taking you through a series of slides that will start with a case study, and then we're going to get into defining what is meant when we talk about antimicrobial stewardship. And lastly, I'm going to discuss with you what strategies, practical strategies exist that you can do to help. In terms of talking about this subject, it's worth noting that as a past member of the Canadian Pediatric Society, there are numerous wonderful guidelines, statements, and practice points to assist people with these topics. One such example is antimicrobial stewardship in daily practice, managing an important resource. Much of what I'm going to talk about here you will find within this document. So we'll start with a case. This would likely seem familiar to you. A 25-week preterm male is born via spontaneous vaginal delivery to a 30-year-old G2P1 mother with no health issues who happens to be GBS negative. The birth weight is 720 grams. This child, like many, is intubated after delivery and given surfactant, is given minimal enteral feedings for 5 days, as is the protocol in our unit. Now, if you care for babies born at these small gestational ages, you would well be aware that things eventually, sadly, often go the wrong way, as much as we try to prevent it. Extubation occurred at 10 days of age. Day 11, however, while on CPAP, this baby started to have increased work of breathing and an increasing frequency of apnea. The clinical examination, however, aside from respiratory distress, was otherwise normal. A blood culture was drawn, and that culture grew coagulase negative staphylococcus. Please note, there was only one blood culture drawn. This situation has played out all over the world and happens every single day. You are presented with a baby who is having some symptoms, in this case an increased frequency of apnea and some respiratory distress. And this follows an extubation that you decided to do. So the question is, does this deterioration actually represent an infection? And how do you interpret and what do you do when you are presented with findings that indicate there just might be an infection there? When we talk about antimicrobial stewardship, it's important to define what we really mean by that. So to begin with, what we say is this is a collection of interventions geared towards optimizing the prescribing of antimicrobials. What this means specifically is that you select the right drug to deal with an infection, you choose appropriate dosing, we ensure that we use the right route, and also important, we choose the right duration of antimicrobial therapy. And we're going to examine in detail how each of these are important. The goal of antimicrobial stewardship is more than just saying that you practice it. The goal of it is to optimize patient outcomes and decrease adverse events related to the use of antimicrobial therapy. Now let's talk about the elephant in the room. One of the challenges that we have in neonatology is that the babies we care for are fragile. And all of us have a low threshold for missing an infection. Infections can masquerade as many different things, and so because we view these babies as so fragile, our threshold for treating presumed infections is actually quite low when you think about how we might approach a child or an adult. So one of the most difficult things that we need to figure out, as I mentioned, is whether or not this is actually an infection. So I'll give you some examples of where it might be clearer and where it gets a little murky. So the first picture on my left is that of an elective cesarean section. There is no labor present, So there's really no reason to suspect that the membranes have had any translocation of bacteria. So I think most people would agree the risk of an infection in a baby who presents, let's say, with tachypnea after birth should be relatively low. But then we have an x-ray like the one on the right, an x-ray where there's haziness. People wonder, could this be pneumonia? Or could this be secondary, let's say, to a precipitous labor leading to transient tachypnea of the newborn? Many will ask, what is the risk of me not using antibiotics? How likely is infection? And we're going to talk about that soon. But then you've got other situations. You've got situations like where a baby is passing blood per rectum and you get an x-ray like the one that just was shown. In that situation, the probability that the patient has necrotized enterocolitis given that x-ray is quite high, and translocation of bacteria across the lumen and across the bowel wall is high. Therefore, most people would recommend antibiotic treatment, if not all. As mentioned, transient tachypnea of the newborn is a common problem that we have in the newborn intensive care unit. And it's one that's actually been looked at to determine what is the real risk of infection in babies who present with an x-ray like the one shown. This paper, which was by Dr. Weintraub back in 2013, examined 745 neonates who had radiographic transient tachypnea of the newborn. In this paper, none of 494 antibiotic naive infants and 212 of 251 antibiotic exposed infants had identifiable risk factors for sepsis. So in other words, the vast majority of patients in this study had an x-ray that was compatible with transient tachypnea of the newborn, but did not have risk factors for infection. Curiously, no infectious outcomes occurred in infants who did not receive antibiotics. Over 90% of the babies never received antibiotics and never had an infection. The message here is, in the absence of significant risk factors for infection, if you have an x-ray in a baby that is compatible with transient tachypnea of the newborn, the luck is on your side, if you will, that if you don't treat and you observe in hospital until resolution of symptoms, you are unlikely to put the infant at any significant risk of serious outcome. Over time, one of the things that doctors and nurses have liked to do is to try to predict or enhance the accuracy of detecting infection. There are so many different things that we have done. And in terms of trying to narrow down which patients are worthy of treatment, which patients are not, there are different tests. The CRP test, the procalcitonin has emerged in recent years. Looking at white counts and left shifts has been around for some time. Talking about the validity or the accuracy of these tests is beyond the scope of this talk, but I would ask you to look at your own hospital and what tests are available and critically examine what the current literature states as to the validity of these tests and the positive predictive values, sensitivities, specificities, and of course, negative predictive values of these tests. But one of the things that we always need to remember is that not all infections are caused by bacteria. One thing we know for sure, given that we've emerged from COVID, is that there's a whole lot of viruses out there. And just because a patient starts to deteriorate doesn't mean one should jump to the conclusion that in fact the problem is a bacterial one. So remember to broaden your differential, especially in the presence of negative cultures. As the saying goes, it's important to compare apples to apples and oranges to oranges. And back in 1988, the CDC, the Center for Disease Control, made a definition of what actually is a microbiological documented bloodstream infection. It requires one of the following. Number one, a recognized pathogen in the blood and a pathogen not related to an infection at another site. Example, a patient who presents with osteomyelitis, who has a secondary bacterial infection in the bloodstream, would be considered to have the primary being osteomyelitis. Number two, fever, chills, or hypotension, and any of the following. A common skin contaminant, such as the one that we recovered, as coagulase negative Staphylococcus, but please note, it should be on at least 2 blood cultures drawn on separate occasions. And the organism, again, is not related to infection that's already been documented at another site. Secondly, it could be a common skin contaminant in the presence of a patient who has an indwelling intravascular device. Lastly, it could be a positive antigen test in the blood, and the organism, again, is not related to an infection at another site. In the case that I presented to you, in which we only drew 1 blood culture, and that blood culture came back positive, according to the CDC, that would not be a microbiologically documented bloodstream infection because there was not an infection at another site, and we only had the 1 culture. So it could have been a contamination. Another common issue that we face is that in intubated patients who develop a new infiltrate on X-ray, people often jump to the conclusion that this could be a pneumonia. It could be a ventilator-associated pneumonia. That may be true, but just because a patient deteriorates, if their X-ray hasn't changed dramatically, or if an ultrasound assessment of their lungs has not changed dramatically, this may simply represent colonization if you've taken an endotracheal tube culture. Criteria that would be more in keeping with a true pneumonia or ventilator-associated pneumonia would be pathogens that are collected in the presence of a changing ultrasonographic picture or X-ray, along with a clinical deterioration such as increased oxygen requirement, temperature lability, hypotension, and so forth. As mentioned previously, it is so important to document a coagulase negative staphylococcal culture on 2 occasions because 1 culture could simply be contamination. And a paper that came out recently in 2024 highlights this. They looked at 139 culture episodes in 120 patients over 3.5 years. They defined a positive blood culture, that would be a true positive, as 2 coagulase negative staphylococcal positive cultures. A contaminant was 1 positive with 1 negative culture, and undefined was 1 positive and no further culture done, which would be sort of what I had done in the case. What they stated was that out of the 139 episodes of true positive bacteremia was identified in 44 of 139, or 31.7%. 30.2 and 38.1 were either actually negative or they were undefined. So only about 1/3 of these cultures that people would have sworn were positive were actually so. Now, one of the realities of working in neonatal intensive care is that our mind plays tricks with us. And how often have you been in the unit and someone has said, when the blood culture comes back and you question, could it be a contaminant? What you're told is, but you should have seen him. He was really sick. But when you think about that, that's a logical fallacy. The reason you did the culture is because they were sick. Certainly not every patient that you do a septic workup on has a 100% positive blood culture rate. So you need to remember that. We don't generally do blood cultures on patients that are not sick. If you need evidence of this, this is from a study which demonstrated, it's the same study looking at patients that had true bacterial infection, contamination, or undefined. And what you can see when you look at a comparison of the trues versus the contaminants or undefineds is that such things that we seemingly associate with true bacterial infections, such as fever, hyperglycemia, hypoglycemia, increased apnea frequency, metabolic acidosis, a high CRP, a different level of white counts, platelet counts. None of these were statistically significantly different between groups. Increased oxygen demand, mind you, was, but it was in the group that had a contamination, not the ones with the true positives. One thing that was strongly associated in terms of differences was the presence of intravenous lines like central lines, longer durations of lines, and being ventilated on the day of culture. But interestingly, again, for the ventilation on the day of culture, it was those patients who actually had contaminants that were more likely to be ventilated on the day. Therefore, it just goes to show you that just based on clinical patterns alone and things like increased apneas or increased oxygen, we shouldn't naturally assume that this means they have an infection. Another thing that I'm often reminded of is not doing the LP at your peril. Meaning, if you do an LP after you've already done the septic workup with blood cultures and started antibiotics, if you get a negative LP, it doesn't necessarily mean that you don't have meningitis. Low white cell counts may also be present at the time of the LP when antibiotics are already started in the presence of such organisms as GBS. So if you think a baby is septic, after the first few hours of life in particular, do a full septic workup. How we collect urine matters. In a study that looked at the collection of urine either via suprapubic aspirate or via a urinary catheter, in 105 infants, what they found was there was a 71.1% false positive rate from catheter samples. So in terms of getting the right test, you might do well to learn how to do a suprapubic. This is the same study which is simply designed to show you the breakdown of how the urine cultures came out based on whether they were from a catheter or from a suprapubic, and based on the urinalysis results. We can avoid needless antibiotics if we maybe choose the right test. Another thing that is really important is knowing your hospital. Resistance patterns of organisms vary based on hospital, vary based on region and area of the world. Therefore, if you want to ensure that you are using the right antibiotic, ask your hospital for their antibiotogram. This can help you in determining appropriate therapy when you need it. The right thing to do is to narrow the spectrum. Narrowing the spectrum of coverage and tailoring it to one organism is far better than using a sledgehammer to kill the one organism. When you've got multiple organism types and you use broad spectrum antibiotics, the likelihood that one of those organisms will develop resistance is higher. Using a narrow spectrum once you identify the organism helps to avoid broad antimicrobial resistance to some of our most powerful drugs. It is the use of broad spectrum antibiotics and not tailoring them down to the right narrow spectrum for an individual type of bacteria that has led to the emergence of things like MRSA, VRE, and multi-drug resistant E. coli as well. If you're looking for a quote, one of the things that you need to think about when you're talking about dosing is that generally prescribers should always use the higher end of the recommended dose range for a specific infection to treat children with normal kidney and liver function. In other words, if you're going to choose a drug, hit the organism hard. Don't use a low dose that they might develop resistance to. Another thing that you need to think about, just like this very short golf course, is always wanting to use the shortest course possible. In other words, give the bacteria the least amount of exposure at the right dose to kill it. And another quote is, why do we treat infections for 7 days? That's how long a week is. That really is what it comes down to, if you ever wondered why we treat most often for 1 to 2 weeks. Don't just take my word for it. There is research on this, including this study from 1998 that occurred in France, looking at strep pneumoniae resistance using long dosage and long treatment durations versus high dosage, shorter durations. And what you can see from the table is that the adjusted risk in terms of developing beta-lactam resistance was high, almost 6 to 7-fold with low dosage. And if you used a long duration of treatment, it was about almost 4 times as high, long course being greater than 5 days. We need to be careful in using short courses at high dose if we really want to minimize the opportunity for bacteria to develop such resistance. As Benjamin Franklin is thought to have said, "An ounce of prevention is worth a pound of cure." What I mean, of course, by that is vaccination. If you're like our center here in Manitoba, Canada, we have a recommended vaccine schedule for children. Vaccination against common organisms is the best way to prevent disease. If we can prevent those organisms from taking hold, we can prevent the emergence of antimicrobial resistance. Depending on where you are in the world, we all have a job to do in trying to deal with vaccine hesitancy. If we fail to deal with vaccine hesitancy and we begin to see emergence of organisms that cause serious to lethal disease, we may find ourselves in the challenging position of no longer having antibiotics to treat established disease, and that is a place that no one wants to be. In conclusion, try your best to treat true infections. The key there is identifying what is a true infection. If you're going to treat, make sure to use the right antibiotic at the right dose for the shortest amount of time. Thirdly, know your local resistance patterns and choose your antibiotics based on your antibiograms. Remember, saying a patient was sick when you drew the cultures and saying that is the reason for continuing antibiotics really isn't a great argument. And finally, we all need to do our part as pediatricians and neonatologists and promote vaccination. Thank you.